Hi everyone. This is the first episode of Rosé with Roops, which is just my take on coffee with Karan, but medical. And I've started off with someone really special to me because he was someone who genuinely loved teaching and who made me really enjoy what I was learning, which is props to him. So I've got Dr. Amrit Nasta with me. He was my surgery professor for undergrad, and he's a consultant in a lot of hospitals in Mumbai, does a lot of fancy surgeries, very cool person, very sassy, if I might add. and I'm going to drop more information about him in the doobly-doo, and you can stalk him on LinkedIn later. But we're just going to have a chat about surgery and what training was like for him in India and just how he got into teaching and a little bit about research. So, should we start? Are you ready?
Sure, we can go ahead, but before we begin, see, if I am Rupali's teacher, I had to be sassy. So otherwise, she would not have been my student. So kudos to her more than to me. So Rupali, begin.
Okay.
Ask me what you wish.
So
Yeah.
the first question I have is, why did you choose surgery? Like, what prompted you? Because I know you were very medically inclined and a very good clinician. So why surgery?
Okay. So you can go even before that. Why MBBS? I was never really keen on doing MBBS in the first place. But when you finish your 10th standard back in the days, and then you have to choose either science or arts or commerce. And if you take science, you have to choose either PCB or PCM. So I was thrown into the day my 10th results came. I was thrown into joining classes, and then that's how I got into MBBS.
Mhm.
It started off when I was even maybe 15, 16 years old. In MBBS, our minds are very confused for many years because whatever we get exposure to, we like. And normally in MBBS in Mumbai, we get good exposure to medicine, surgery, a little bit of OBGY, pediatrics. Those are the main clinical branches we get exposure to. So it becomes very easy to develop a liking for any of them. We rarely see radiology, dermatology, anesthesia. Those are quite unexplored. So the liking never develops. I feel I developed a liking for surgery maybe in my final year of MBBS because that's when I saw these branches little more closely and I felt okay, in surgery you are actually in the heart of action. It's not too much of imagination. It's not very abstract, it's very concrete, and you can see the result on the face. It's not too much of thought process, more action. That's what really drove me into surgery at that time. Would I regret going into surgery? I wouldn't say so, but currently not many people prefer surgery after MBBS, which is a fact. So yeah, it was the exposure that I got. I also had good mentors. Like when I was in final MBBS, I had good people who helped me in surgery more than other branches. So automatically the liking developed.
Right, that's a very interesting point because I think the people we meet along the way who tend to guide us and help us figure out what we really like.
Yeah,
Um,
or maybe they push us into hating something. Like
yeah,
in a lot of places, the OBGY department teachers are not very cooperative.
yeah.
So we automatically develop a disliking unknowingly because of the people we meet.
That's true. I think even it was similar for me in JJ. OBGY can be very taxing as a branch itself. And if you don't have really good teachers, it becomes harder to develop a liking for it. Okay, so since you've mentioned your mentors, we'll go into what was residency like for you. Do you have anyone you specifically remember as being quite sassy and quite lovely during your training?
So my UG was from JJ, where Rupali did her UG from. And JJ was a beautiful place in terms of you had a lot of freedom. There was not so much of hardcore competition, at least in my time. I don't know how it is today. Today, everywhere there is hardcore competition. But in JJ, you had your space. I did my PG from KEM and I chose KEM, because I felt I should get a change of scene. It should not be continuing in the same place. And when I got into KEM, it was a very competitive space. The departments, the workload was enormous. So you barely got any breathing time, and which is continuing till today. So even now, they are such busy departments that the 3 years of residency just go in a jiffy, and
Mhm.
you're like, what the hell did really happen? So the department at that time was a very tough place. Now things have, of course, eased out because the people who were senior at that time are no longer there. They have retired. So things have opened up. Now there are more residents. So it's a little bit easier to handle. But work wise, exposure wise, there was too much to do. So you were never really using your brains. I felt the whole 3 years of residency, barring the last 2, 3 months maybe, were done at a spinal level. And we never really thought about what we were doing. Maybe we made so many mistakes because we were never really reading anything.
Right.
So when I was preparing for my MS exam, that's when I realized, okay, this should not have been done like this. The breast cancer patient should have received chemotherapy, but we just didn't know. So like that, there were a lot of things which, because of the workload and not getting enough time to study, were not so good in the entire residency process. But yeah, exposure wise, you saw everything under the sun possible.
Right. I think that's something I've really stressed upon. In at least we were lucky enough in government setups in Bombay that we had so much workload. We saw such interesting cases that it really pushes you to explore more in medicine and surgery and figure out if you actually want to see more of this or not. When you were doing your MS, is there anyone in particular that you remember who stood out and you still like remember particularly?
So I would answer it in two fronts. One were the people who I was working with, who were my peers.
Mhm.
So they were a very big support system because every other day one of us was getting bashed up for making mistakes. So we were helping each other out.
Right.
And when we passed out and we finished our residency and we went into practice, we are still very connected. And the ones who are practicing in Mumbai, who are in a similar branch, we are still helping each other out and participating together. So that bond of MS has continued till date, and I passed out 10 years ago. So I am still in touch with the people who are I worked with then, who helped me then. Maybe I help them, my roommates who are practicing here.
Mhm.
So the circle that you develop amongst your peers really helps. In my seniors, there was some really beautiful mentors who taught you not just how to operate, who made you realize that in surgery, we always, students always ask me, should I join this place? Will I get enough cutting?
Mhm.
That's their favorite word. Cutting milegi ki nahi? And I tell them, cutting mile na mile, what you need more is the pre-op preparation and the post-op care, which nobody really teaches. So I got good opportunities to work with people who taught me this aspect of surgery, not just the cutting. There were some very gifted surgeons, but they were naturally gifted. So you cannot replicate their surgical skills. It's not possible. It's like Roger Federer or Sachin Tendulkar. Nobody can be like them.
Mhm.
But the skill set that is required pre and post is what I really learned from some good mentors, and how every surgery has to be planned.
Right.
And each and every operative step has to be anticipated to make the surgery safe and the outcome safe. So that kind of learning I was very fortunate to receive in my residency.
I think a lot of that cutting aspect comes from like pop culture and media where you just want to like be in the OT. But I really liked your approach of how you saw the patient as a whole, as a person who needs continuous care throughout and not just a piece of meat or a bag of like organs to cut through. Yeah, so that was
Yeah,
really interesting. And
I'll give you a, if sorry if I may interrupt, I'll give you a simple example. Uh, Now we are all in private practice. And if I am a bariatric surgeon, and let's say there are 10 bariatric surgeons in Mumbai, and there must be some who are very senior to me. If a patient comes to me for a consultation, why would he choose me to get operated from? It's based on how I talk to him, how I convince him, how I make him feel safe. How I perform in the OT will be the same as any of the other surgeons. But what he sees, the impression that is generated when he meets me, those are the skills that you need to learn. When I say pre op, talking to patients and making them comfortable has nothing to do with cutting. It is to do with the skill sets that you develop over a period of time that nobody wants to accept. They just want, okay, I've done 500 hernias in my residency and now I'm a hernia pro. But when you go in private practice, patient will not see that. He will see how you talk to them first.
definitely, because I think we are just focused on what training is like for our 3 years or 5 years
Yeah,
doing super specialty, but there's a life after that.
yeah.
And can you tell me a bit about what the scope is like post surgery in India?
So I'll put it in a certain structure because that's how you must have seen even in our classes, everything was in a certain system. So once you pass out, one of the ways you can start your practice is working in a government setup where you have a safe job. You'll have a fixed pay every month, whatever happens, and you'll have people working under you. So it's a fairly stress-free job. It's not for someone who's very ambitious because it will not help you make big bucks, and you won't become very, very famous if you're working in an institute of a government background throughout your life. But yeah, job security is there and there is no pressure.
Mhm.
They're never going to fire you. The second way to work is working in a so
Okay.
EMM.
So, can you tell me a bit about what the scope is like post doing surgery in India?
I'll give you an idea, a little structure of what are the different options that we have after completing our MS or even after completing a super specialty like in surgery if you do urology. So normally if you're practicing in a city like Mumbai, you have three ways to go about it. The easier way is for people who don't have too much of responsibilities, who want a peaceful life, that is to take a job in a government setup, like one of the BMC hospitals. So it's very easy to get in the hospital. You will have a lot of people working under you. So you are not going to be on call all the time. It becomes fairly easy to manage, but you'll have a fixed pay. And whatever happens, the pay will remain the same and it will increase a little bit over time. You may get promoted, but it's a very stress-free job. You'll have summer holidays, you'll have Diwali vacations, and you can take leaves quite comfortably, and nobody will ever fire you from your job. So at least till you retire, it's a safe place to be. But yeah, in your career, you can't really grow because the opportunities are fairly restricted. The next way to go about it, especially if you have done super specialty, is to work in a corporate hospital as a full timer. So it's like how you have a full time job in NHS.
Mhm.
Those jobs are well, they pay you well. Getting those jobs is not that hard, but those jobs are not very secure. So if you don't, a lot of hospitals make you, you have to attain some targets, like at least these many surgeries have to be done in a month. So if you don't meet those targets, it's possible that the job will be lost. And while you're working for a hospital, you're not really the boss. You don't call the shots. The third way to work is what a lot of people like me are doing nowadays is freelancing practice, where you take attachment in the hospitals. Hospitals will give you the attachment, but getting the patients is all on you. So you have your own OPDs, your own camps, your own PR. Getting the patients is your thing. And then you call the shots, you operate wherever you want. So these are the three ways to go about it in a metro city like Mumbai. And depending on your level of ambition, you can pick and choose and always change along the way. So there are ample opportunities in the surgical field if you go by any of these three pathways.
Right, and it's really interesting how you've mentioned the difference between, say, government practice and private practice and your own setup.
Yeah.
I just have one question because I remember you mentioning that DNB, in terms of training, can be a good option. So, can you tell me a bit about why you think so?
I feel MS is a little overhyped because of two reasons. One is, as I was saying before, you're not really using your brains if you're working in a very busy department. So we feel we get a lot of exposure, but are we really learning? I feel it's not so. And nowadays, we don't want only to work. We want time for ourselves, even if it's 3 years of residency. We don't want it to be too hectic. So that is one. We need some social life, which will not happen in an MS in a government place. In a DNP place, whatever you learn will be evidence based because it's private practice. You are under a consultant, and the consultant will only follow what is most acceptable. It's not going to be taking a chance, which in a government setup you can. You can do surgeries or even, just to get the hang of it. It's acceptable, but that will never happen in private practice. So, whatever you will learn, it may involve lesser exposure, but you learn the correct things, the correct techniques of everything. And because it's not very busy, you have time to read, time to study, understand what's happening in every case. If you feel after DNB you didn't get enough exposure, you didn't do 100 hernia surgeries, you can always work for a year or two in a government setup and get the exposure then, which is fine. There is no bond in DNB, whereas MS has a 1 year bond. So even to do a super specialty, you still have that 1 year hanging in between to complete. So I feel DNB is very underrated.
Right, that's really interesting because I think having time for personal development and getting opportunities to learn is really important because we forget that our residency, PG, is not just about service provision. You're not just
Yeah,
there to work all the time. You have to learn things, which is
and you're
hard.
getting a degree, you're going to become a surgeon or a physician. Are you
Yeah,
really becoming, or you're just working robotically?
exactly. You have to be able to develop that thinking more than just, or the skills, knowing how to do it more than key. Like this is just the plan to follow. You have to develop that skill and acumen to make those plans yourself.
And आप ही
Okay.
सोचो ना, if in your ward there are 40-50 patients on a given day, how much time are you really going to dedicate to each of them? Maybe you'll talk to them for 2 minutes. What are you going to learn? But in a private setup, if you have to see 5 patients, you will take full history, full examination. Your consultant will explain each and everything about the patient. So automatically less patients, but more quality learning.
Right, definitely. I wholeheartedly agree with that. Going from training and learning to a little bit about your other side hustle, if I may call it, of teaching. Can you tell me about how your journey into teaching started and what prompted you into taking this up?
This I would say began maybe when I was in my internship in JJ, where I would always like to ask my peers or my juniors questions when we would see patients. And really, when I entered PG, when I was in my third year, and students like Rupali, not at that time, but people who were senior to her in KM, they would come and ask me to teach, and I started teaching them informally. Little things here and there, and then I realized I'm getting a good response. So when I finished my residency, some of the students of that time told me, why don't you give it a chance and do it professionally and see how it goes? So the first year, the first time that I ever taught, that was 8 years back, I got 12 students. That was my first ever practical batch. And in that year, I took 4 or 5 batches. Each time I got 12, 13, 12, 13 students. So I got about 50, 60 students after teaching 4 practical batches. Year after year after year, it went on from 50 to 70 to 80 to 100. And this year, I had to take only one practical batch in which I got over 240 students. So the transformation and the growth automatically was encouraging me to continue. And more than side hustle, it has become more a main hustle because uh, it's not very heavy duty compared to doing surgeries all the time. So it gives me a little peace of mind and it is something I'm enjoying. So this side hustle is kind of like a peace of mind for me.
Right. I understand what you mean by like you like teaching and then it all organically grew into becoming bigger. And what are some of the things you've learned just from starting out with like 12 people and now becoming a group of like 200 plus?
So over the years, what I have noticed the most glaringly is that the attitude towards education has gone for the worse. So students like in Rupali's time, maybe 3, 4 years back, how they were so enthusiastic and they really wanted to learn is not the same anymore. So now if I say I'm going to teach 20 cases, they are not so happy. But if I will tell them, I will teach them 10 cases, which are the most important ones, they are more than happy. They want to learn less in a short span of time, feeling whatever is adequate, only that much I want. They are not really hungry to learn. And the biggest drawback of this is the lesser you learn, the lesser you will remember, let alone exam, but even later on in life, whatever skills that you pick up in your education will help you somewhere along the way. So many of my older students tell me, oh, I saw this case and I remembered you taught us this in thyroid or you taught us this in obstructive jaundice. So those kind of things will always remain with you. But if you are not going to want to learn 20 cases, 30 cases, but you're happy with 10 cases, that's all I'm going to give you. So the loss is yours. Instead of saying teachers more and more, they want me to teach them less and less.
I think that's such an interesting example because even now, if I get like a jaundice case or a obstructive jaundice case, even if they weren't like high yield for the exam. And I think that's one of the drawbacks that we've got because of competitive exams becoming so important that it's you've got so much to learn in such little time that nowadays people are focusing more on learning for the entrance rather than learning to become a doctor, which I think has been a loss overall.
I also
Do
feel
you
they are
have an approach?
I also feel they are quite misguided when it comes to preparing for exams. They feel having a focused exam kind of preparation is the need of the hour. It is not so. Exams have changed. Now they
Mhm.
don't ask too many factual questions. And really speaking, your best preparation for these exams is what you learn over the 5 years of MBBS and not just in the last few months of your internship when you're about to appear for the exam, where you just want to, mug up each and every fact that you feel will come in the exam. That is no longer the case. Only those who have been studying 5 years are the ones who will crack the exam. So it's a misconception of sorts that I need to be exam oriented.
Mhm. I definitely agree. I think building concepts overall throughout MBBS is really important. And do you have an approach for undergraduates for specifically surgery? Because it can be quite daunting in final year with so many subjects. So, how do you think is the best way to go about it?
I feel since the exam patterns have become so clinical, if you study your final year subjects well in final year, or even start off with one or two subjects in your third minor, it will help along when your internship. What I say is, if you studied your final year subjects properly in final year, then your internship, you are only going to have to study first and second year non clinical subjects. And then preparing for entrances becomes really easy. So the exam pattern, even for final year, has changed since this year. So they have gotten a new pattern, which is quite daunting in itself, way more daunting than preparing for the entrance, which they are not, students are quite unaware of. So now they are not asking, question answers straightforward, like they will tell you, write about breast cancer, which would have been coming in Rupali's time. Now they would not put it like that. Now it will be a clinical scenario that there is a 60-year-old lady who has a breast lump and blah, 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 blah. And these are the findings. And how will you proceed with the investigation and management? So that can be developed only by proper understanding and not by exam oriented studying. Till we don't accept that, clearing any exam is going to be very difficult. Forget entrance, even final year results have become quite, on the downside in the last couple of years.
Right. I think with the changing curriculum and the focus on clinical learning and developing that acumen, hopefully going forward, people will be more interested in genuinely learning for the love of learning rather than just memorizing for exams or entrances. So we've spoken about your training, we've spoken about undergrad learning. What about when you're a postgrad resident? What would be your approach for learning, even if it's hectic in MS or if it's quite chill in DNB?
Uh, when I enter first year of my MS or DNB, I don't really get time to read anything. But the one thing that I must do is I must prepare for my thesis.
Mhm.
That is a big burden in the years to come. So first year should only be about thesis preparation and getting the clearances done and getting the hang of the work hours. You should start studying properly from your second year, and there are standard books which you should use. And of course, whatever you are seeing in the wards or whatever you're operating, those things should definitely be read on the same day if time permits. So it will get ingrained in your mind. When it comes to your exam time, you will not have the time to read each and everything, but whatever you've seen is what you'll remember the most. So preparing should go in this order, where first year for thesis, second year for starting the studying, at the same time seeing and reading what you experience in the wards. And third year will be more focused exam level preparation.
That's a really smart approach, especially I think with a lot of Indian postgrads thinking about Royal College exams and just doing fellowships abroad. Do you think it makes sense to start thinking about these things in PG or wait until you're done, or how would you
Uh,
approach?
I am not one who wishes to rush through things because
Mhm.
many times we just go with the flow, and sometimes we see our peers doing something and we are, enticed, and then we feel maybe we should be doing the same. So regarding future fellowships, you should take your time, make full use of your residency first. Preparing for exams like MRCS can be done after your residency also, because you'll of course be more mature.
Mhm.
Simpler parallel would be preparing for USMLE in your MBBS. When students
Right.
ask me, should I give step one in my third minor? I would always say no. Give it in
Mhm.
your internship or when you're going for your electives, because by then you have enough clinical knowledge to help you with your preclinical subjects. So
Right.
cracking the fellowship exams becomes very easy once you've studied for your MS exams.
Right.
And you are more mentally mature because you've seen so much.
Definitely. I would like 100% agree with that because we are so rushed because it's our mentality ki jaldi khatam karna hai, jaldi khatam karna hai. But what are we achieving jaldi khatam karke is the question. So we've covered undergrad, we've covered concept-based learning. Specifically for exams, do you have some tips in terms of how to study surgery or anything you want kids to really focus on?
I'll tell you what they focus on and what they should focus on, and they are poles apart. What they focus on is app-based recorded learning,
Mhm,
where I'll give you how things have transformed. When I was in MBBS, we used to learn in the wards.
mhm,
Maybe even when Rupali was in MBBS, ward-based learning and classroom learning was what was happening. Things have gone from wards to classroom to learning in libraries where people read books to now, if you go to any college library, you're not even going to see students reading books. You will only see them on their cell phones where they are reading or watching recorded material or pre-recorded notes or ready-made notes. Notes will never replace a textbook, and what you see will never replace what you see in a video. So this focus has to go back to our traditional ways where you read from the books and see in the words, and that will last in your memory for a much longer time. You can use ready-made notes only when you're preparing for entrance, but otherwise core learning has to be in the words and from the books. Nobody knows what is Balian love and what is esbas in surgery anymore. They have forgotten it. It's a forgotten concept. They only read ready-made notes. That will not help you in any exam or in any aspect of your life.
yeah. I think I was more familiar with the review books for exams than I was with ever Bailey and Love. I'll be honest, I never read it. I did read my roommate's notes of Bailey and Love. So, but I do agree. I think I definitely agree about the ward-based learning because I remember personally the cases that I saw in the wards. Then I did what I read in the textbooks. So
Sure.
I
That
think a
that goes
good
without saying.
combination of all of it would be a better thing than just videos.
uh, our mentality is if I have finished all surgery videos from a certain app, I know surgery. My
Yeah.
surgery is complete. But that is another misconception. Just watching a video does not mean you know the subject. Even if I watch surgery videos, I still am unable to grasp, even though I've been doing surgery for so many years, I can't grasp the surgery video. So, how can a student who is 22 years old, who has no exposure to surgery, grasp from a video? It
Correct.
is something that has to come out in the open that this is not the right way to go.
I think it's a convenient way to learn. It's not the most effective way to learn. I
It,
think we can leave
uh,
it at that.
it is the most convenient and the least effective way to learn.
Yeah. So moving on from teaching and learning to a little bit about research, because I know as we go on in our journey from undergrads to postgrads, thesis, as you mentioned, comes up, and that's research. Can you shed a bit of light on what your experiences in research in surgery have been? And
So the first ever research that I did was actually, going with the flow when I was in JJ. And my girlfriend at that time, when I was in second MBBS, told me, oh, there are these ICMR researches going on. Are you planning to do it? I was like, okay, I have no clue what that means. But that's when I got started. That was my first ever study. And then it got approved. And then I ended on finishing it. So it was a very simple study. It was on hypertension in young population. So we checked that, do college students have hypertension? We had some selection criteria. And that was my first ever study. In MS, I barely had any time. So I started going into research and publications from my last year of MS and my SR-ship. And you started off with simpler things like case reports. When I entered private practice, that's when I realized how important it is to have research on your CV. And over the last 7 years, I must have been a part of first or second author in at least almost 25 publications, simply because it makes you more acceptable in your circle amongst your peers. So we feel, okay, research, it's all fabricated, it's all made up. It's not so. It brings you recognition. So today, if someone wants to decide for a certain conference who should be called to speak on a particular topic, what will they do? They will not call their friends. They are going to check on Google Scholar or on PubMed. They'll put the topic and they'll see how many people have researches on that topic. And then they find the most suitable or the most evidence-based research and call those people to speak on that topic. So it brings you more recognition. And of course, needless to say, the more you research, the more you are aware of the mistakes in your own practice. So till when you do research, you use your own data. And usse you will understand that, okay, what I felt was a good practice is actually not good practice because my patients are having complications, or in bariatric, my patients are not having enough weight loss. So till you don't audit your own data and publish it, you will, it's like being blindfolded. You are blind to what is really happening. So more than building your recognition, it also builds your clinical practice.
It's really good that you brought up the ICMR, like the researches that go on, because I was rejected. My project was rejected, and then it really pushed me to look into more of research. So I think it's important that undergrads are given the opportunity to at least look into these things
Yeah.
and figure out if they like it. You might hate it, and that's completely fine as well, but at least have the opportunity to see what it's like. And
Rupali,
yeah.
allow me to interrupt you. Let me ask one question to you,
Mm-hmm.
if I may. Let's say you finished your residency in India
Mm-hmm.
and you have applied for a job in a corporate hospital,
Mm-hmm.
and there is a candidate who's just like you with a similar qualification, and I am your interviewer. How will I decide whether to choose Rupali or to choose the person B for the job if both have similar credentials? Or rather, what do I seek in your credentials when I'm trying to appoint you, in your opinion?
I think because we've gone through a lot of interviews, I've realized it's something that sets you apart from your peers.
Okay. For
And
example,
it can be anything. Like I've realized it can be research, it can be teaching, it can be audits that you've done. Anything other than, like, everyone does MBBS, everyone studies, everyone gets good marks. But it's what makes you different. And I think having the clinical knowledge as well. We can't just be.
how do I measure clinical knowledge?
You asked me a question in the interview. You asked me a case. That was what was
Okay.
done with me. I was given
Okay.
a case.
Oh, okay. So I'll tell you how people in corporates hire.
Yeah.
I'll tell you how I was hired. So if
Right.
there is a big competition for a spot in a company,
Mm-hmm.
the first thing that they will see, they will not see where you have done your undergrad, postgrad from. They'll see your work experience.
Correct.
So do you have 1 year, 2 years, 3 years versus you have zero work experience, but you have done your PG from a good place. That PG from a good place holds lesser value than
Mm-hmm.
post PG 2, 3 years of work X. First thing is work X. The second thing that they see are your researches.
Yeah.
So if you have work X and you have researches under your name where you're first author, second author, and they are not just retrospective, maybe prospective studies, then
Mm-hmm.
you are right at the top. Then they see other things like where you did your postgrad from, how you are to talk to, how you are as a personality. But what we feel when we are in our academic journey is, oh, I did my UG from this place and my PG
Yeah.
from this place, and my life is sorted.
Mm-hmm.
Those are much lower tiebreakers in the big scale of things. So
I
this,
definitely agree. For sure. That's something I've been trying to tell people, and it's
yeah,
really nice to hear from someone like you who's been through probably a lot more interviews than any of us have ever. And it's really refreshing to get that perspective. Ki there is a job that you apply for at the
yeah,
end of
yeah.
everything. Yeah.
So students in final MBBS are so stressed. God,
Mhm.
please help me pass, help me pass. And I tell them, you pass. What's the big deal? In India, every year 1.5 lakh people become MBBS. You're just one of them.
Yeah.
Same as for NEET PG. You get a rank, it doesn't mean anything. Okay, it opens some opportunities, but you can make good or you can, really ruin those opportunities if you don't use them wisely. So
Right.
getting a rank is also not as big or as big a hype as we make it to be. It's your learning and what you carry forward in future, which how much ever I try to grill into their minds, they don't accept.
I think the biggest learning out of this video or podcast has to be please padhai kar lo and do more than just padhai, I
And
think.
don't do padhai just to pass an exam.
Yeah. Yeah.
पास हो गए तो क्या बड़ी बात है. They don't understand. नहीं बस भगवान, I just want to pass. Passing is meaningless.
It is. Try to excel at whatever you're doing. Basically,
Yeah,
don't just go with the flow. Try to learn and try to be good at what you are. Be really
yeah,
good at what you are. And
yeah.
success. वो थ्री इडियट्स का डायलॉग नहीं है.
कामयाब
जॉब
बनो,
मार के पीछे आएगी.
काबिल बनो, काबिल,
हाँ,
कामयाबी जक मार के पीछे आ जाएगी.
exactly.
Confirm.
So I think we'll end it on that note. Thank you
Sure.
so much, Amrit
Thank
Sir,
you.
for joining me and giving me your very valuable time from all the teaching and the surgeries and cool stuff you're doing.
I hope I was sassy enough to match your standards.
Very sassy. I loved it. Thank you for
Thank
thank
you.
you for
Thank you.
joining.
Thank you.